Okay, looks like we are recording now. So welcome everyone. Thank you for joining us. Looks like we have a few more people joining in. My name is Jen Bentley and I'm the Alumni Engagement Officer for the Faculty of Health. But I'd like to begin today just by acknowledging that much of the work of the University of Waterloo takes place on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. Our main campus is situated on the Haldeman Tract, the land granted to 6 nations that includes 6 miles on each side of the Grand River. Our active work towards reconciliation takes place across our campuses through research, learning, teaching, and community building, and is centralized within our Indigenous Relations Office. And we've also been fortunate to have our own Indigenous knowledge keeper within the faculty. And you may have seen some events recently that have been hosted on our BMH Green and within our buildings hosted by him, Mayan Henry. So we're very fortunate to have him within our faculty to share more and have more learning happening, which has been great. So yeah, I'm excited to welcome you to this is our final week of office hours for this term. Today featuring Kinesiology grad Matt Clements. Bringing alumni back to connect with students is an important priority for both the Faculty of Health and the broader university. Alumni help show students what's possible. The success that they've had and the stories they share help to shine a light on the path that students might be interested in for their own futures. So we host this office hour event series every term. If you do have any requests for careers that you'd like to see or information you'd like to get out of these sessions, please feel to share your ideas with us in the chat. We're always looking to give students what they are looking for and wanting to learn from, so your feedback is welcome. In order to make the most of this small group session here today, it'd be great if everyone would be willing to turn on your cameras and join the conversation with us. We're hoping that this will be a great group discussion, and it's always nice if you have friendly faces to look back at as opposed to just a blank screen. So if you're able to turn on your camera and be a part of the conversation with us and Matt today, that would be great. And when it does come time for questions, you'll be able to raise your hand through the reactions button. There's a raise hand option, so you can use that to ask your questions that you have for Matt today. And on that, I will introduce Matt. So Matt is a 20+ year paramedic in Ontario with experience in land and air ambulance in both rural and urban settings. As a critical care flight paramedic, he has the privilege of moving some of Ontario's most critically ill patients from accident scenes and community hospitals to larger tertiary care centers. He is also fortunate to be part of the faculty team in the paramedic programs at Fanshawe College. He has taught lectures and lab classes in the primary care, advanced care, and community paramedic programs. He is a member of his workplace peer support team, where he helps colleagues to manage the
sequelae. Sorry, I used a big word.
You did use a big word and I wasn't ready for it.
The consequences
of their stressful work environment. Thanks for your help on that, Matt. And I will pass it over to you to share more of your experiences and your journey from your time at Waterloo to where you are today.
Awesome. Hi, everybody. Thank you for the intro there. That sort of paints a quick picture of sort of what my career has looked like since leaving Waterloo. Excuse me. Yeah, so I graduated from Kin in 98, and then I guess summer spent some time doing some soul searching and applying to colleges, and went to Algonquin College in September of 98. I graduated in 97, didn't I? So it was 98, I graduated from Algonquin. and then started working as a primary care paramedic in Arnprior, Canada, sort of on the west end of Ottawa, and then got sucked into the air ambulance system and have sort of been there ever since. So yeah, that's sort of it. I'm currently working for Ornge out of our London base. So we're based at the London airport. I work on the helicopter that's based there. Yeah, and then on the side, I teach part-time at Fanshawe in their paramedic programs for primary care, advanced care, and sometimes in the community paramedic program. So yeah, that's basically what I'm up to these days.
That's great. Thank you for sharing that. And I mean, most of what our session here today is for our students to get to ask you questions about, you know, probably mostly your work as a paramedic,
Sure.
but how you got there. I don't want to assume any questions that the group has, so we can just jump right into Q&A with the students. And so I know some of you signed on after I said this, but you can just use the raise hand feature to ask your questions. And I do encourage you to turn your mic on and have an actual conversation with the group to ask your questions. So does anyone want to start off with the first question for Matt? Let's see if I can pull one that was submitted ahead of time. So one question that was submitted in registration was, did you have any career paths that you were debating between?
So I was in the co-op program and spent the last like 2 or 3 years worth of work terms working in a health and safety department at a food processing plant, actually doing like job safety analysis and some like light ergonomics stuff. So that was sort of where I was headed. I'll also say I had done a work term at Humber College earlier on in my schooling, running their anatomy and physiology lab for, among other programs, the ambulance and emergency care program, as it was called at the time. And just talking to faculty and students there and hearing about their experiences, that became sort of a passing interest. So fast forward like 3 years later, when my co-op employer didn't have a job for me, once I graduated, I thought I'd go with plan B. So started looking into college programs sort of across Ontario and started sending out applications. So yeah, I had sort of thought about going the health and safety route, but yeah, once I got down that path of going to college, it's just been sort of one door opening up after another, and I just keep walking through them. So yeah, here I am.
Great. Thanks for sharing that. One thing I meant to do before we jumped into questions was some introductions so that we know who's joining us on the call today. So I'm going to call on a few people who have their cameras on, if that's okay. And then if you're not able to use your mic and camera, you can just put your program and what year you're in into the chat for us. But Christina, would you mind going first?
Yeah, sure, not a problem.
And maybe you can also tell us what interests you in coming to today's session.
Of course, yeah. So I'm a recent grad from Waterloo. I actually just graduated last week.
Congratulations.
Thank you. My next step is actually going to Humber College for paramedicine. So if that's not obvious as to why I'm here, that's exactly why I'm here. I want to learn a little bit more. Yeah, that's basically it. I have a interest in paramedicine. I was on the campus response team at Waterloo, if anyone's familiar with that. And I look forward to learning a lot more in this session along with everybody else.
Excellent. I am happy to mislead you in all sorts of different ways.
Looking forward to it, definitely.
Great. Jana, would you mind going next?
My name is Jana, and I'm in the graduate program for Masters in Health Informatics. So this office hour is basically, it's out of curiosity. I'm a registered nurse. I've been a nurse for like 7 years, and I have some of my colleagues who went to kind of similar routes. They are flight nurses. So I just wanted to know more about the differences in the scope of practice. And I'm personally not going to pursue that career, but I'm curious. I want to know more about different routes, just because like it's my personality. I like to know more.
Awesome.
Yeah.
That's great. Well, we're happy to hear or have you here. I'm sorry, I can't tell from your username what your first name is. Sorry, if that's your full first name.
The guy with the Thriller shirt.
Oh, it's Azhan. Sorry.
Azhan, okay.
Showing up clearly or not, but nice to meet you guys. My name is Azhan. I am pursuing a degree in kinesiology, and it's my second term here at Waterloo. And
awesome.
Medicine is one of the career pathways that I'm looking forward to. That's why I'm here today. Thank you.
Great. Thanks. Yashika?
Hi everyone. I'm Yashika. I'm in kinesiology. I just finished my 3B term here. I was interested in joining because I had to figure out what I need to do career-wise really soon, and I am interested in healthcare-related careers, so I wanted to learn a little more about it today.
Awesome.
Thanks. Emily, are you able to come on? She said she's in a shared workspace, so maybe not. Zohal?
Hi, my name is Zohal. I'm a UW alumni as well, and I am currently doing my master's, but was also just interested in learning more about the session and what paramedicine is, and interested in the healthcare field as well. So yeah, that's why I'm here as well.
Great, thanks. Okay, Emily put her intro in the chat so everyone can read that. And then lastly, we have, I'm sorry, I'm not sure how to pronounce your first name. Isi?
Hi. Yeah, it's similar to that. It's Eche, actually.
Sorry, Eche.
No problem. Yeah, that's good. Sorry, I missed the introduction. I joined a little bit late from another meeting, but I'm happy to introduce myself. I'm a PhD student in the Systems Design Engineering department, and I work on a project that is about critical care, and I think that was catching my attention when I read the email about this session today. I'd like to hear a little bit more about your field and your impressions and your path probably. I'm having a great interest in how critical care clinicians do work. I worked a lot with the physicians, experts, and fellows actually in the past term, and I'm always very curious about a couple of new perspectives as well.
Sure. Awesome.
Great. I love the variety of interests here in the group today. This is great. So we can jump back to questions for Matt. It seems like they might be a little bit of everything here for you today. Wondering if there's anything else you want to share based on some of the introductions you just got there.
Yeah, I think it is just sort of in general terms, I can hopefully help to paint the picture of what paramedicine in general is, and then sort of what I do as a critical care flight paramedic specifically. But actually, you know what? I had a whole bunch of notes that I went through and read everyone's questions and stuff. So one of the things I was going to post here is, I'll just put it in the chat here, but there's a link there for the Ontario Paramedic Association has a page that sort of spells out what the scope of practice is for the varying levels of paramedicine in Ontario. So essentially there's 3 levels. There's primary care paramedic, advanced care paramedic, and critical care paramedic. Technically, there's a corresponding flight designation at each level. So primary care land, primary care flight, advanced care land, advanced care flight, and so on. Most of the paramedics in Ontario are primary care paramedics. So most of the ambulances that you see driving around town are going to be staffed with 2 primary care paramedics. The scope varies a little bit depending on where you're working, but in general terms, primary care paramedics are carrying like 10, maybe 15 medications. Most of them are able to start IVs and do like manual defibrillation. So we don't get to use the paddles. We put great big stickers on and shock people that way. But that's sort of the primary care scope of practice. The advanced care scope of practice is that, plus they add in some more delegated medical acts, like intubation is probably the big one. So putting in a breathing tube into somebody's trachea so that we can ventilate them more effectively. They'll also carry more in the way of IV medications. Most of them are centered around running cardiac arrests. So they're giving IV epinephrine or atropine or lidocaine or what have you. But they also carry medications for managing seizures. And that's sort of where the big difference is between primary and advanced care. When you get to the critical care level, or the advanced care flight level, is where things really start to diverge between land and air ambulance, in Ontario anyway. When you start working on an air ambulance, you'll do like on-scene trauma stuff, like landing at car accidents, industrial accidents, horseback riding accidents, ATVs, all that stuff. And pick the patient up at the scene and fly them to a trauma hospital. Around here, those are like London Victoria Hospital, Hamilton General, Toronto St. Mike's, and Sunnybrook are sort of the closest ones. So we do that stuff where we're landing on scene and picking somebody up. The other half of what we do, though, is interfacility transfers. So we're picking patients up at, pick your smaller hospital and then moving them to a tertiary care center where the required level of care is. So once you start doing that, now you have to be able to run a ventilator. You have to be able to give continuous IV infusions of medications. We do things like invasive monitoring, we call it. So I can't put in an arterial line, but I can monitor an arterial line. So an arterial line is just, everybody's familiar with a blood pressure cuff. It goes on your arm, you pump it up, listen with the stethoscope and get a blood pressure. Invasive monitoring is a little different, where they'll put a catheter, like an IV catheter, into an artery, typically the radial artery, but it can be anywhere. And then the tubing from that goes to a pressure transducer, and it gives you a real-time measurement of what the patient's blood pressure is. So once we can do that, then we can start running some of the heavier medications that have like really short half-life, really short time to having an effect, and we can adjust them appropriately in real time. So the critical care stuff, we start to get into the interfacility stuff, and we're moving kind of the sickest of the sick around Ontario. So that's sort of broad strokes what the differences are between primary, advanced, and critical care medics.
Yeah, that's cool. I think we all see them flying around, or we see ambulances around, but it's interesting to know the different levels and skills of the people doing those jobs.
Yeah, so in Waterloo, you'll have, I don't know if everybody is still based in Waterloo here, but you'll have mostly primary care paramedics, but there are certainly advanced care paramedics working in Waterloo. Sorry, when I say Waterloo, I mean Waterloo region. EMS or Waterloo Region Paramedic Services. I think really the only place you're going to find critical care paramedics is working for Ornge, or Toronto EMS does run some critical care ambulances in the GTA. So yeah, if you're working for Ornge, then we have bases all over the province. So you're either working on planes or helicopters. We also have some, some land ambulance bases as well. So like Peterborough, Chatham, there's one in Markham, there's one in Ottawa. Yeah, so it's, yes, we're flight paramedics, but we're not always working in a flight environment. So.
Yeah. Feel free to, just to everyone, raise your hand at any time that you want to jump in with a question. But I'll keep going off some that were submitted through registration while the rest of you think about what questions you have.
Awesome.
But somebody asked, what are the top 5 qualities needed to be a successful flight paramedic?
That was a great question. And I didn't want to put memory down as one of them. So I need to refer to my notes here. Let me see here. Where did I have this written down? There we go. So top 5 qualities I came up with. So first one isn't much of a surprise. I said resiliency. There's a lot of stresses around working in, like as a paramedic, you're sort of, I guess, you're dipping your foot in a lot of different pools. So in some sense, we're considered healthcare workers. So you've got all the stresses that go along with that. And we're also considered first responders. So you've got all the stresses of emergencies and all that sort of stuff. And then there's just the labor stuff. So we do shift work. So you've got all the stresses associated with doing 12-hour shifts plus or minus whatever overtime you might be subject to. So resilience is a huge thing. It's been in the press a fair bit over the last few years that mental health can be a huge challenge for healthcare workers in general, for first responders, but certainly specifically for paramedics. So you certainly need to actively improve your resilience in whatever ways that's meaningful for you. So for me, it's I see a therapist like once every 2 weeks to once a month just to check in or to talk about things I've done or whatever. So I mentioned I'm also on the peer support team at work supporting my colleagues. And I think that has made it very apparent to me how important it is to be actively involved in establishing your resilience and looking after your mental health. So yeah, I see a therapist on a regular basis. For me, it's not because there's huge ongoing issues. It's more just that I like to have a relationship with a therapist that I maintain, so that when I do need to talk about something, I'm not then looking for a therapist and having to explain all the background, like my whole story of 20 years of paramedicine and where that's led me. So that's the way I do it. Other things that when I'm supporting my colleagues, that I try to reinforce with them are things like, are you getting enough sleep? As a shift worker, you really have to figure out how to manage that and maximize the amount of rest you're getting. Are you getting exercise? Super important to be doing that. Are you eating healthy foods? Because it's so easy to fall into the trap when you're in an ambulance for 12 hours and maybe not ever making it back to base where your lunch is. You're just picking up whatever you can on the go. Really easy to fall into the trap of not, looking after what you're putting into your body. And then the other thing is just social contacts. Like, have you got a good network of people that you can socialize with? Not even so much to be able to vent about all the things you've seen at work, but it's important to like unplug and do something other than paramedicine and be able to hang out with friends and just do something that is not at all related to your work. And I think those things probably apply regardless of what field you're working in, but super important for paramedics in my experience. So resilience. I think another thing that's super important is your communication skills. I spend my days building like ad hoc teams with strangers, trying to problem solve our way through some really complicated, serious situations. So if I can't communicate in a way that puts everybody in the room at ease and gets everybody on board with what my plan is, then it can lead to chaos, which obviously isn't terribly helpful when you're trying to resuscitate a seriously ill patient. So yeah, communication, huge skill. I think you have to have an aptitude for being able to learn and integrate medical knowledge, especially if you're working at the critical care level, because we don't have a lot of direct oversight. So, most critical care is done in the hospital where you may be working as a critical care nurse, but you've got a respiratory therapist there. You've got, other nurses working with you. You've got layers of physicians in their hierarchy that are looking after the patient as well. So you've got lots of support and lots of direct oversight. But when I go out, it's me and my partner. And I've got a physician that I can call on the phone and discuss the case and ask for advice, but there's nothing physically that they can do to help me with what's going on. So you kind of have to be on top of your game in terms of the diagnostic skills and the therapies that you're going to be providing. So you've got to be able to wrap your head around sort of staying current and being on top of best practices. I think the fourth thing I've got written down here is being able to function in high stress situations and be able to do some problem solving. So critical thinking is a huge requirement for us. You have to be able to fairly rapidly assess a situation and come up with your plan to deal with it. You don't always have a lot of time to work your way through that. So a lot of it is falling back on your training and just having like a structured approach to how you go through a call. That helps a lot for sure. But no two calls are ever the same. So you've got to be able to adapt and overcome, as they say. I think the last thing, and probably the most important, because it ties into so many of the other things that I've talked about, is just you have to be someone who wants to help. You have to be there for the patients. And this is something that we see in the flight environment every once in a while, is that we'll get new hires or recruits who want to work on the helicopter because it's cool to fly around on a helicopter. And I got to tell you, if that's what's driving your career decisions, it's not going to be a terribly enjoyable career. The shine of flying around in the helicopter comes off after about 6 months or so. Like at that point, it's just a loud, cramped, shaky, sometimes hot, sometimes freezing cold place to try and do your job. So if you're just there because you want to fly in helicopters, then that gets old. But if you're there for the medicine and the things that you can do to help your patients out, that will help with your resiliency and help with your understanding of what's going on. So super, super important, because in paramedicine, we train for like the worst case scenarios, right? Like we spend our time learning how to run cardiac arrests and how to manage multi-system trauma patients and how to deal with septic shock and all these horrible things that some of our patients present us with. But that's fine because we have to know how to do that. So we spend a lot of time training to do it. But the reality is, in most ambulance settings, the vast majority of what you do is going to be low acuity, social problem type calls. You're dealing with, well, I mean, you guys all know one of the biggest drivers of somebody's health outcomes is their socioeconomic status. So you're dealing with people who have found themselves in a position where they simply can't look after themselves for whatever reason. And a lot of that is socioeconomic stuff. And you're dealing with psychological issues, you're dealing with addiction issues, you're dealing with, failure to thrive sort of situations where people just don't have the skills or the knowledge to look after their health conditions. So it's not always like running around with your hair on fire, running cardiac arrests. And if you're someone who's not there just because you want to help, regardless of what capacity it's in, then you're going to struggle with the low acuity stuff. We see a lot of people get burned out. And I think that's a big driver of it, is because they go into the profession thinking it's one thing, and then the reality sometimes doesn't line up with that. So yeah, you got to want to help. That's the last one and the biggest one. The end.
That was great, though. I think there were a lot of learning points through those 5 skills. Yeah. So thank you for sharing that. I had a question that came out of one of your answers. Sure. And when you were talking about going to see a therapist, and I was curious to know, like, as a career, what the support is like, and like the benefits that you get through work and being in a position where you're in healthcare and a first responder. Like, how is that supported in paramedicine and by Ornge? Okay,
so I can give you the very political answer that we're looked after just fantastic. The reality is, things have come a long way. Like when I started working in 1999, I guess it was, that was very much the suck it up, buttercup sort of approach to mental health care. Like, okay, I understand you just did that awful call, but there's more calls waiting. So get in the truck and go do more calls. And we didn't talk about mental health or the effects that our calls had on us. That has really shifted in the last, I'm going to say 5 to 7 years, where people are recognizing that, yeah, there's some pretty serious consequences to spending all your time seeing horrible things. Like the rates of suicide for paramedic are, I want to say they're about double the normal population. Don't quote me on that, but it's high, and people are starting to recognize that. So There are more resources available in terms of like charity services, and groups like, say, like Wounded Warriors of Canada offers a bunch of great programs for first responders. So there's been an upsurge of things like that. In terms of my benefits specifically at work, like I said, we have our peer support team. So there are paramedics around the province who have done some training, like the mental health first aid course and things like that. We have a social worker on staff who sort of leads that team, and he's fantastic. You won't find a more experienced, trauma-focused social worker than our guy. So we've got that in-house, which is nice. Some land services have comparable sort of teams, but not everybody is there yet. So that's still building in some places. In terms of my benefits, I think I get, I forget if it's $500 a year, I think, that I can spend on therapy, which I don't know if any of y'all have been to a therapist lately, but you can burn through $500 in about 2 sessions. So for someone who's like dealing with mental health issues, it's not enough. So it's mental health care, I think, just across the population needs some work and some extra funding, and we're no different than any other group that way. But within the profession, I think people are more open to discussing just amongst ourselves, just debriefing after calls or sharing what we're going through. Much more open to that than it was back in the olden days when I started. So
thanks for sharing all that. And it's I mean, I guess it's nice to hear that it's improving. But yeah, my husband's also a first responder, so I understand some of those challenges.
Yeah, it's not easy, and there is still a bit of that culture where people are afraid to ask for help because I'm the guy that shows up to help, right? So if I need help, then what does that say about my ability to help other people, right? Whereas if I don't ask for help, I don't need help, then obviously I'm still ready to go out and do my job, and you can do that for a period of time, but we see it catch up with people way too often.
Yeah, for sure. Jana has a question.
Yeah, well, my question is a little more specific, but it's a follow-up for what you said before. Well, working as a nurse, we always deal, probably you too, with shortages, right? And on the top of all the stress, sick calls. So how paramedics, or your service specifically, Ornge, deals with sick calls? And like on the top of that, if you can kind of go over what your team is and what the responsibilities are, because some of my colleagues who work as flight nurses, they said it's like you must have a pilot who can also do CPR and something like that. But because in my province, I haven't heard that paramedics can be a flight, like work as in that service. It's only nurses, so that's why I'm not familiar with Ornge specifically. So if you can go over like more technical stuff and yeah, how you deal with shortages if you have a sick call like 1 hour before your flight, for example, and you have a partner, how are you going to deal with that, or how the company deals with that?
Yeah, for sure. No, it's a great question. It's Ontario has a fairly unique air ambulance service in that we are staffed with 2 paramedics on each crew. So it varies geographically. Most North American services run either nurse paramedic or nurse RT, respiratory therapist, or nurse physician sometimes. In Europe, you'll see many more, like there's a physician on every crew, because their philosophy is a little different. So in Ontario, we have air ambulances to pick up the patient and move them to where the required level of care is. Where in Europe, the philosophy is much more, we're bringing the care to the patient. So they'll have like an anesthetist, a critical care physician on the aircraft, and they'll start doing stuff at scene. There really isn't much of a difference in terms of benefits one way or the other. It's just two different approaches to the same problem. Ontario has just evolved that way over the last, I think the first air ambulance in Ontario was 1977 or something like that. I think it just politically, it was under the Ministry of Health, under Emergency Health Services branch, which ran a provincial land ambulance service at the time. So they started a provincial air ambulance service. So I think their paradigm was just paramedics work pre-hospitally and nurses work in the hospital. In Ontario, you will see nurses working in transport, but it tends to be exclusively with pediatric and neonatal transport. So hospitals like London Children's Hospital, Sick Kids in Toronto, CHEO in Ottawa, McMaster, all run pediatric transport teams, and they're staffed with a nurse and an RT. But they don't have their own vehicles. Well, I shouldn't say that. Some of them are getting ambulances now, but if they require a flight somewhere, then it's us. We pick them up, fly them to where they're going. They do the patient care and we fly them back. In terms of how our individual teams are structured, we always fly 2 pilots and 2 paramedics. And there's a pretty clear delineation between their duties and our duties. So the pilots look after flying the aircraft. They're checking the weather and doing all their pilot stuff. So they sit up front and look after that. The medics are in the back, and we look after patient care. And I find it's actually a nice thing to have that delineation, so that the pilots are looking after the safety of the aircraft. And when they're flying, they're not second guessing what I'm doing in the back because they've got medical training and they think they know better. And maybe they do. But at the same time, if we're flying in sketchy weather and I'm cross-trained as a pilot, I'm not sitting in the back now second guessing the decisions they're making up front. I can focus on patient care and make sure that I'm doing the right thing for the patient all the time. So that's just sort of how the Ontario system has evolved. But you're right, there are certainly differences in other jurisdictions. In Ontario, Ornge is kind of the big player, but there are other charter aircraft that we have access to. So we have our dispatch center in Toronto will field all the air ambulance calls. And if it's appropriate for an Ornge aircraft, then they'll dispatch us. But some of the lower acuity or more long-term planning stuff, they have access to other smaller companies that run generally with 1 primary care paramedic on the aircraft. And that's for the guy in Pickle Lake that's got to come down to Thunder Bay once a week for dialysis. That sort of stuff is done by those aircraft. In terms of how a call is structured, for the scene calls, it can vary a little bit, but generally somebody dials 911. I just saw this huge accident at the corner of A and B, and they'll get put in touch with a land ambulance dispatch center. You call 911, you talk to the cops first, they'll shuffle you over to the ambulance dispatch center. If the dispatcher thinks it's something that warrants us responding, then they bump it to our dispatch center. Sometimes that doesn't happen until the first paramedic crew gets on scene and they're like, oh, wow, actually, this is worse than was advertised. Let's get Ornge involved. So our dispatch center calls our base, tells the pilots we've got a weather check for a scene call near Milverton. And they say, we'll check the weather and call you back. They go look at the weather and make a yes or no decision based on the weather. Either it's good or it's not. If they say yes, then we've got about 10 minutes or so to have the aircraft off the ground and be en route to the call. The charter services that I spoke about, I think generally run more on like a 1 hour call out sort of thing, where the call comes in, the pilots will check the weather. If they accept it, then there's an hour for the medics that are on call, for the pilots to get themselves to the airport, get on the aircraft and get off the ground. So yeah, that's sort of the broad sweeps. The interfacility stuff, if there's a patient in the ICU in Owen Sound that needs to go to London, they call Critical generally, which is another whole story that we don't have time to talk about, but they'll generally get put in touch directly with our dispatch center. And then the process is the same. They call us, we check the weather. If it's good, then off we go. So I don't know if that answered all your questions. Oh, you were wondering about crew shortages. Yeah, it's tough these days, actually. In the midst of COVID, I think we burned some people out for sure. Same as anywhere in healthcare, like in hospitals, they're short staffed just chronically now. So yeah, we'll have people that come in on overtime or double overtime to fill shifts. We'll bring people in from other bases if we can do it that way. So yeah, it's a challenge for sure.
Thanks, Matt. Covered a lot of questions there. Jana, I'm curious, where are you located?
I'm in Manitoba. Yeah.
Manitoba, okay.
Yeah.
Okay. Manitoba has a fairly new air ambulance service over the last couple of years. So I think STARS has come in there and is running the show. I'm not sure about Manitoba, but I think they typically run like nurse RT or nurse paramedic. Actually, I think it's a nurse paramedic crew typically with STARS. And then they bring a doctor along if the patient is on a ventilator. Okay. Typically, where with our scope of practice, we will run the ventilator ourselves. It's just a matter of training and just sort of how things have evolved.
I actually had a question, like if there is a laboring patient, I know it's not maybe your specialty, but if its mom is in labor and with preterm baby. So you mentioned that, neonatal team, but in this case, if it's like mom and the baby, like what is happening in this situation?
Yeah. So obstetrical calls are, for me, those are some high stress calls because I don't do a lot of it. In Southern Ontario, we're fortunate to have a lot of really good obstetrical resources available to people that are fairly accessible. And generally, if something like preterm labor happens, either they can handle it in a smaller hospital or they're accessing the service early enough that they can be moved to wherever the higher level of required care is. Now in Northern Ontario, it's a different story. They do a lot of obstetrical stuff and they deliver babies while in flight and all sorts of craziness because they're flying into small landlocked communities that don't have a road out. The only way in and out is to fly. And there's a nursing station. So there's one nurse, there's no physician, there's, that's the care that can be provided. So the patient has to be moved out. And, if somebody shows up late and they're like, yeah, I've been in labor for the last, 12 hours and just decided to present now, then yeah, sometimes that puts us behind the 8 ball a little bit in terms of being able to provide the care. But we're all trained to deliver babies and resuscitate neonates when need be.
So for how many weeks young?
So when I started,
what's your limit? I mean, legally.
The baby comes out and we resuscitate it.
At any gestation age?
Well, it's so The neonatal ICUs will generally take patients down to a certain age. So in Windsor, I think they're down to something like, they'll do down to like 28 weeks. If it's less than that, then it's got to go to London. We don't always have the benefit of being able to screen our patients and say, yes, we can deal with that, or no, we can't. So for instance, when I started working land ambulance in Canada, I was on my 3rd day. So this is fresh out of school. My 3rd day, I was sent to what was advertised as a fairly low acuity call. And then just as we pulled up in front of the driveway, they're like, yeah, it turns out this is actually a call for a lady in labor. Sounds like she's 26 weeks gestation, and it sounds like she's delivered. So sure enough, we go in the house and she's sitting on the toilet and holding a baby in her hands. And she asks, like, is she alive? I'm like, it's 26 weeks, born outside of NICU. Like, there's no way this is ending well. And then the lips moved. I'm like, yeah, she's alive. And so we start doing our thing. And, you know, long story short, 2 years later, I'm told she was starting to hit all her milestones and stuff. So, now this is in Ottawa, so she got transported to the Queensway Carleton Hospital, which is a fairly small center, but CHEO is just down the road. So they were able to get her into a neonatal ICU fairly quickly and provide that care. But like, we're like a 911 service. So whatever comes up, we're dealing with it.
Yeah, that's impressive. 26 weeks is very rare, I would say, exception.
Yes, yeah. I came to realize that shortly after that.
Yeah. Oh, my other question, sorry, if someone, it's my last one maybe. So as I understood, Ornge is it provincially funded then, or it's a private company? I'm kind of confused. Sounds like it's private, but funded by province?
Yeah, it is kind of a confusing thing. Technically, we're a not-for-profit, and our only customer is the Ministry of Health. So we're provincially funded, not-for-profit, sort of arm's length. We're not technically a Ministry of Health entity, but yeah, that's how it works.
Interesting. Yeah, because I thought Ornge was similar to, that laboratory services. Like they're really private for profit, but they're funded almost exclusively by government, by provincial government. Interesting. Okay. Yeah. Thank you.
Yeah. Thanks.
Great
question. I see another question there.
Yeah. Hassan, go ahead.
Thank you. Matt, my question was, earlier on in the meeting, you talked about how there's a huge social aspect in this job. And I just wanted to know, how do you guys deal with, patients who don't want to be treated, even though they're in extreme danger and they don't want to go to the hospital?
Yeah, that's a good question. It's tricky because every patient has the right to refuse care, right? So now, when we're faced with a situation like that, we have to consider capacity. So it's fine that this person is saying, no, I don't want to go to the hospital. But if, in my opinion, they really need to be going, then it becomes a matter of, does the patient actually have the capacity to make that decision? So I have to be able to explain to them what the risks are of not going to the hospital, why I think it's important to go. And if we judge them to have the capacity to be able to make that decision and they still say no, then they still say no. Like I've heard it said that people have the right to make bad decisions. So, we'll give them options. We're like, we're one phone call away. If things change, you change your mind and you want to go, then give us a shout back. Those sort of situations don't happen terribly often. Most patients are pretty open to putting their trust in your clinical expertise. And generally, again, this is where the communication skills come in. Sometimes you got to be the good cop, and sometimes you're the bad cop, and you got to figure out what approach is going to work best with this patient to get them the care that they need. But it's tough. I think most people that call do want to go. Some people just want some reassurance that they're okay and that they don't need to go. But yeah, generally speaking, it's a matter of explaining the risks and hoping that they get on board.
All right. Thank you.
Yeah, thank you.
Another question that was sent in was about what is the most difficult part of your job and how do you keep from burning out?
It's funny. I wrote in my notes under that question, I said, I don't keep from burning out. Burnout is just a reality of the job. Like there will be times when you have sort of reached your peak or you're outside your window of tolerance. If you want to Google that, that's something worth looking up. But there's just times where you've reached your limit and that's it. So in terms of how I deal with that, because I mean it's like, make no mistake, I see some awful stuff, right? I'm not going to go into details about it because I don't want to relive my trauma for the sake of our discussion. So it can sometimes be a challenging question to ask a paramedic, like, what's the worst thing you've ever seen? Odds are you don't want to know. But so much of it is about preventative stuff. So the things I said before about making sure I'm getting enough sleep, that I'm getting some exercise, that I'm trying to eat healthy, that I try and have social contacts outside work. If I can have hobbies, like I dabble in photography. Anything you can do to sort of build your resistance to try and keep you in a place where you're inside that window of tolerance is really the best strategy. When I reach the point where I've had enough, I'll probably start with my partner, because odds are they just went through the same thing I did. So we'll sit down and have a talk, and are there things that we could have done differently or should have done differently, or whatever the situation is. If that doesn't work, I've got my peer support team that I can reach out to. I'll call our social worker and talk to Tom directly and work through that. And generally, that's more than enough to get me back to a place where I'm ready to do the next call. But like I said, like I'm not shy about seeing a therapist and talking to them about things I've seen or had to do. And I think just that constant maintenance of trying to build as much resilience as I can, so that I've got a bigger buffer, really is the only way around it. Because I don't control what calls I get sent on or the things I have to see. So I've just got to try and prepare myself as best I can for whatever the phone is going to bring next.
Yeah. Thanks for sharing that, Matt. And I think even, those things apply to, you have a lot harder of a job, but I think people can take those tips to apply them to any work and career situation as well. So just looking at the time, we're close to the end. Our Yashika would like to, I think, take a screenshot of us for social media.
Yes. Yeah, if you're not comfortable, it's going to be posted on Twitter. So if you're not comfortable with your picture or your screenshot being on Twitter, you can turn your camera off. But yeah, I'm just gonna set up.
But if you don't mind, for a quick smile, that'd be great. And you'll count us down, right?
Yes, please. All right, 3, 2, 1. Good.
Awesome. Thank you, everyone, for that. And yeah, it looks like we're already at 1 o'clock. I feel like that went really fast.
One thing that I can do, I mean, I'm not in a huge hurry, so if people have questions, that's fine. But one thing I can do is I'll give you my work email.
Yeah, if you want to put that in the chat.
Post this in the chat. So I can't promise how quickly I'll get back to emails, but that's probably the best place to catch me with any work-related stuff. So
that's great.
Yeah.
Well, yeah, if anyone has any other questions, feel free to reach out to Matt. Christina, maybe you'll see him in school.
Yeah, good luck at Humber. That's awesome. It's a good school.
Oh, right, different school. Sorry, I mixed that up.
I mean, it's no Fanshawe, but.
But yeah, so Matt, thank you so much for joining us today. It's been great. I learned a lot from you, and I hope everyone got something out of our talk with Matt today. We truly appreciate our alumni giving time back to talk to, actually, I think today was mostly new grads and alumni. Is anyone, Yashika, are you the only current student, or Azhan, you too?
I'm a current student as well.
Yeah, great. So a nice mix of students and alumni here today. Thank you all for joining us. I will mention you'll get an email for a quick survey in your inbox after the session. It's really just choosing which smiley face emoji you'd like to rank us. So it takes probably 30 seconds to fill out that survey. If you could do that, we'd appreciate that. And otherwise, if you have ideas of other speakers you'd like to see us featuring, feel free to send me an email or connect with me on LinkedIn. And yeah, happy to put more alumni careers in front of our new grads and students. So thank you all for being here. And Matt, thank you so much.
Oh, thanks you guys. That was a lot of fun, a lot of really good questions, and hope you all got something out of it. Like I said, drop me an email if you have any more questions, and we'll go from there.
Great. Take care, everybody.